Good afternoon, everyone. Myself, Dr. Kirti, Assistant Professor, Physiotherapy Department. So now we'll discuss about sign and symptoms of rotator cuff injury, their diagnosis, and their treatment. So tendinopathy symptoms include discomfort, which can range from ache to sharp localized pain. There could be the common point of tenderness in the front of the shoulder, which is more accessible when reaching behind the back, along with lateral deltoid pain, which is more journal in nature with no associated point tenderness in that area of shoulder, and increased symptoms with raising and lowering of arm, especially in the horizontal or shoulder level range of motion. So there could be weakness for most shoulder arm movement, especially when lifting the arm overhead or with resisted external rotation. So there could be acute rotator cuff tear symptoms, like common mechanism is sudden fall on outstretched hand or rapid loading of shoulder muscle, like from ground or opposing player. There could be tearing sensation in the shoulder immediately followed by significant pain. Degree of limitation with active shoulder movement secondary to pain and weakness. There could be severe pain in specific location followed by spasm and journal shoulder joint stiffness. So depending on degree of tendon or muscle disruption, the resulting weakness can range from minimal to severe enough to impair any active abduction of the arm. There could be chronic rotator cuff tear, which develop over a period of time due to excess impingement type friction related to more chronic pathology. It usually takes place at or near the tendon, usually found on dominant side. There could be gradual increase in both pain and weakness, both of which can get severe, and there could be increased symptoms with rest and while sleeping on involved side. And athletes with symptoms tend to be 35 plus in age, and depending on location and severity of injury, limitations in range of motion weakness will vary. Next, we are having the examination. So history and physical examination include inspection, like in chronic cases there could be flattening above spine of scapula due to the wasting of supraspinatus. Deltoid may be more prominent on affected side due to fact that shoulder joint now communicates with subdeltoid bursa, which may be distended with fluid from joint, so pushing out the deltoid. So palpation, there could be tenderness localized to greater tuberosity or bursa. We can check the range of motion. We can do some MMT. Then special tests like lift off sign or drop arm test, knee abridgments, and then Hawkins Kennedy we can also perform. So this is the MRI or ultrasound. Then arthroscopy. We can advise the patient just to rule out the diagnosis. Then non-surgical management. So management in painful shoulder syndrome without any dislocation. So their symptoms may be chronic in terms of long standing or recurring. If there is inflammation, the initial treatment priority is to get inflammation under control. So in the protection phase, we can control inflammation, promote healing. It's very important to educate the patient. It's and also to maintain the integrity and mobility of the soft tissues or muscles, control pain and maintain the joint integrity, and develop the support in related regions. So in controlled motion phase, so once the acute symptoms are under control, or we can say once the pain subsides, so the main emphasis becomes the use of involved region with progressive, non-destructive movement and proper mechanics while the tissue heals. And patient education is important. We can put the patient on the home exercise regime. Also develop a strong mobile scar. It's very important to educate the patient about the ergonomics plus postural awareness. We can also modify any joint tracking or mobility, balance in length, strength of shoulder girdle muscles. So in return to function phase, it's very important to make the patient functionally active. So functional outcome begins as soon as patient develops the control of posture and basic component of desired activity without any exacerbating the symptoms. Then surgical management, it could be arthroscopic approach, it could be mini open approach, it could be traditional. So usually the anterolateral incision is done from the middle one third of inferior aspect of clavicle across the coracoid and to anterior aspect of proximal humerus. Then we can again start the physiotherapy management, same as that of the conservative management. Thank you.